Hi everybody, I'm Laurie Cadden and we are at Geisinger CMC's professional office building because we are doing a little story for you on Stop the Bleed or trauma surgery. We have a wonderful guest with us. His name is Dr. Brian Frank and he is a trauma surgeon at Geisinger CMC. We are doing this as part of our Lackawanna County Medical Societies, as you know, Brian, public education how about me, public health education series. And so we're going to talk a little bit about, you told me earlier that May is Trauma Awareness Month in Pennsylvania. You also will be doing a Stop the Bleed Day at Geisinger CMC. So I'd love everybody to know, what is Stop the Bleed exactly and how was it started?
So Stop the Bleed is the CPR equivalent for patients who have life-threatening bleeding. It came out of the Sandy Hook Elementary School shooting and the Hartford Consensus, where we had folks who got together from all different walks of life, be it police, fire, EMS, physicians, politicians, all got together and met to see how we can approach these national preparedness issues out of the President's directive, President Obama, at the time, and recognizing that much wasn't going to change with regard to gun control, they changed their mission into saving lives. And so the first step was to integrate response for fire, police, and EMS to get to victims faster, but the other side of that was rendering care sooner. And part of that is Stop the Bleed, where we empower the lay public and the first responders or the immediate responders and the immediate bystanders to begin rendering care because they'll have the knowledge and they'll have the tools to treat those victims immediately.
I understand the knowledge of where you should tie something or use as a tourniquet to stop bleeding. But to use the other things, would they be equipped eventually to have in your cars, in your purse, or how would you have those things available?
Yeah, everything needed to control bleeding is readily available. As crazy as it sounds, you can get it on Amazon, you can get it at Walmart, you can get it at sporting goods stores. What we teach is the knowledge of how to use what you have readily available to stop bleeding. So it's just like Mom taught you. If you cut yourself and you're bleeding, you hold pressure. We don't do much more than that. As frightening as it sounds, as a trauma surgeon, that's our goal, is put pressure on the bleeding site. But we give you the education and the knowledge to use something like a tourniquet, tell you why the wound packing is effective and why we use wound packing devices. So all these things, we teach you how to put a kit together. It's relatively cheap to do so. We give you the resources and the know-how of putting together a kit yourself and where to get the supplies. And we do, although it's not advocated by the American College of Surgeons, talk about improvising tourniquets if necessary.
So like if you had a necktie on or something like that, take it off. And is it true, now this I saw in The Good Doctor, when the very first show, some young child there was shards of glass that went into him and he cut something in his neck area. And there was a doctor on site and this other young guy who is the good doctor, and he was pressing, he was holding. So does it depend on age of the body where you should actually apply the pressure to stop it? Because they said that, and I wasn't sure, I never heard of that.
So as far as direct pressure, you want to do it directly on the site of bleeding. Obviously, there are concerns where if a person has a piece of glass in their wound that you could make it worse or you could hurt yourself. So we want to be mindful of that. And never pull it out, right? You should not be pulling it out in the field. Leave that to the experts.
Right.
As far as a tourniquet is concerned, you're limited to using that on the extremities. And unfortunately, some extremities are bigger than others and others are smaller. The tourniquets are designed to be one size fits most, and they'll fit many larger extremities, but for kids and some littler adults, the tourniquet won't be effective.
Okay. So then that's when you do
direct pressure and holding pressure for at least 10 minutes or until medical help arrives.
So you said something very interesting when you started this, is you said that most people, when they lose a life, it is because of loss of blood. So whether it's internally where you can't see it or externally where you can then apply pressure and use a tourniquet, that is really because what happened, the loss of blood just becomes so great that there's no turning back, the organs start to slow. What actually happens in that case?
So hemorrhage or exsanguination or blood loss, it's the most preventable cause of death in trauma. And when we talk about number of years of life lost, unfortunately, young people are disproportionately exposed to trauma, specifically bleeding trauma. So we lose, unfortunately, a lot of years of life. What happens is blood is essentially what carries oxygen, nutrients, and energy throughout your body. And without that blood, systems shut down, your kidneys, your liver, but ultimately your brain and your heart.
Okay.
And so patients who are in the latest stages of shock from hemorrhage, they become unconscious, they look floppy. Before you die, they look dead. And unfortunately, unless you act quickly and immediately, there's no turning back.
And we're not teaching anyone things we can't teach, but when that would happen as a stop the bleed, the tourniquet, I understand that's what what's part of that. But what if there is internal stuff? What could people do in that realm to help someone who they may come upon because of the laws possibly or probably won't be changed, and to rally against that, look at what you can do. So what would somebody do in a case like that where it's not visible?
Right, so if somebody has internal bleeding, so we're talking chest and abdominal bleeding, number one is activate the 911 system. And that's with any hemorrhage. If somebody has life-threatening bleeding, you want to call 911 and get them to the hospital as quickly as possible. But for torso bleeding in particular, you can bleed to death from an artery in under 3 minutes and from a vein in under 10 minutes. So time is of the essence. If that happens, somebody has a gunshot wound or an injury to their torso and they're bleeding to death, in the field, the things that you want to focus on are keeping them warm. You can try to keep them alert, but ultimately the physiology, the lack of blood will win out and get them to the hospital as quickly as possible.
Okay. So when this Stop the Bleed came into existence because of Sandy Hook, which God bless them, and this whole thing happened, and Pennsylvania has a month of May, and other states probably do too, or maybe it's just a national thing now, I don't know. But when that all came about, how did the medical profession respond to the fact that, hey, we are now telling you, Joe Q public, what to do to help us before they come to see someone like you, because you're right there. How did it take, do you think the medical profession grasped it and thought, hey, let's make this right because you are our first line of defense now? Or was it a little like, just as we were talking, we're not trying to teach you something you can't do?
Right.
Where did it stand with that?
This is the most exciting and the most popular outreach from the American College of Surgeons, which is my parent organization. This is something that's incredibly exciting to us, and we've been very successful getting it out into the public. I recently presented at a national conference on this very topic to show how effective the training is. And the conference was in Orlando. Orlando Airport has the bleeding control boxes next to their AEDs throughout the airport. The Disney staff were trained in how to stop the bleed. God forbid something happens at Disney World. It's an incredibly visible target that would have a lot of impact nationally for the wrong people. But their staff is prepared to do this. So it's incredibly exciting for us. There's still internal debate. One of the big ones is, do you teach how to improvise a tourniquet? So using my necktie or your scarf, should you be improvising a tourniquet? And purists say absolutely not. It doesn't stop bleeding. And then on the other side of it, you have folks who say, well, in the Boston Marathon bombing, for example, there were a lot of improvised tourniquets, and those victims made it to the hospital with a life, probably because the improvised tourniquet, while it didn't stop bleeding, at least slowed the bleeding. And so there's some internal debate in what's appropriate for teaching and what's not, but ultimately this is, at least the goal for the American College of Surgeons, is to have 100% of trauma center participation in the training.
The other thing I think that happens in a traumatic situation in general, and I think it's neat to know this, is when something happens, as I said, traumatically, you sort of your adrenaline kicks in and all these other things start taking over, that you almost, when you step back, you think, how did I do that? I don't remember doing it. How did it happen? Does that happen, do you think? I mean, I know you're a medical doctor, so you were trained in this, but does that sort of happen when you see these things? You do this for a living. The adrenaline in these rooms coming in must be through the roof because of everybody pulling and grabbing and doing, and yet there's a calm about you and the staff that is kind of surreal, knowing what's actually happening. So that really does take place.
There is. Samuel Shem, who's a psychiatrist now, he wrote the book House of God, which is essentially Bible for anybody going into medical training. And he has the laws, and the first law in a code situation or a patient's in extremis is the first pulse you check is your own. And so you really need to take a deep breath, calm down. If I were to walk into a trauma bay excited and hyped up and my heart rate's going 150, you can bet the rest of the room is going to be hyped up, and the volume escalates and it gets harder and harder to control the situation.
It's almost like, in a weird kind of way, it's almost like a play, or in the sense that everything around you is all that you don't know, so many moving parts. This is happening, what's happening here? Let's get this. I can't even imagine how you or any of your group, your team, do the work you do, and how does one decide in life, this is what I want to do as a doctor? How did you ever decide? Because looking at you now, you're this calm, cool and collected guy. So where do you go with that? What made you want to do it, or did you fall into it and think, hey, in your training, this is what I do best?
Yeah. My wife joked with me before I finished my residency training that there was one career she did not want me to do, and she never limited me on anything, but she said, the only thing I don't want you to do is do trauma and critical care. And I fell in love with it, and that's what I do. And she's always been supportive and is happy that I enjoy my work.
So she doesn't say, nah, I told you. No.
She does say I told you so, because she also said I knew you would want to do this. Because a big part of what we do is not just the emergency and trauma care, but is also the critical care support for those patients. And taking care of somebody sick is incredibly rewarding, because we do see the other side of it, is we can get them better and get them through their hospital stay. As far as keeping calm and keeping the tone, like you said, it's like a play, and we script it. We have an ATLS, or a trauma life support script, that we follow, where we support airway, breathing, circulation, disability, expose the patient. And that's just the primary survey, and the secondary survey is just as scripted. And we rehearse with our ER staff and with our nursing staff, and we do drills and practice time and time again. And so while there are nuances and variables in every patient, it's scripted and rehearsed, and it should be the same every time.
So do you actually, when something happens and a surgery has to be performed in a trauma unit, do you go to an operating room, or are there many operating rooms right off of a trauma area?
That's dependent on the facility.
Okay.
The emergency department, or the trauma bay where the patient will arrive, is equipped to handle life-saving operations. Without getting into too many of the gory details, if somebody were to lose their life because they're shot and they bleed to death, the most heroic measure we can do in the trauma bay is what's called a resuscitative, or an emergency department thoracotomy, where we open up the chest and access the heart. And we can do that in the trauma bay, but more often than not, we're able to get that patient to the operating room to do our definitive operation there.
And what happens with the heart when you do that? What do you do with that?
So the procedure involves us getting into the chest, draining the other side, because we're going in the left side of the chest. We drain the right side of the chest at the same time. Nurses are getting IV access, or members of the team are getting central lines or large IVs. And while that's happening, we're clamping the aorta, which is the main vessel from the heart to the body, to limit the blood return. So we're going to transfuse the patient at the same time, but I want that blood staying in the heart and going to the brain and going to the lungs. And then we will open up the lining around the heart, make sure there's not blood welling up there that's causing the bleeding. And if we find a hole in the heart, or a hole in the lung, or a hole in a blood vessel, we'll temporarily patch that until we can get to the operating room.
Because arteries take blood away from the heart and veins bring blood to the heart, correct? Okay. You know, I was a nurse for 7 months, so just remembering. But I said nursing school for 7 months, and I promptly quit. Could you imagine why? But I think it's fascinating, because I said to Dr. Frank earlier, how did you get here? Are you from the area? He said, no, but my wife is. So we give a big shout out. It's Renee, you said? So it's Dr. Renee Frank. She's a pathologist, you said. And so you know the difference. And I think maybe, Renee, you were doing a little reverse psychology there. Don't do it, even though you knew he was good at it. But so she's she's a DuPont native, so you're here. And what do you think of our little area up here in northeastern Pennsylvania? What do you think of us? So you're from originally?
New York.
The
city area.
Yep. Oh wow, what a difference.
Long Island.
Wow. And here you are. What do you think? It's easy to get home, right,
to
your neck of the woods?
That was a big draw, is the traffic, or lack of it up here.
And so we have the Geisinger CMC and all the things that go on. And I would love you to tell our viewing audience, could you tell them a little bit about if it's a calm day for you and everything, what does your day look like when it's, give a little explanation of what your day consists of in your team in an average day of trauma surgery.
Sure. We start our day by signing out to each other. So our whole team gets together in the morning and we talk about all the patients on our list. And on slow weeks, that means it's a good week for the community, so we're fine with that. But we'll talk about the patients in the ICU and on the floor. Our rounds then split and we see the patients in the ICU and patients on the floor, and we take care of all of their systems. Trauma is a whole body but also whole person injury complex. So patients have to suffer PTSD after their traumatic injury. There are issues at home because people didn't plan on needing to come to the hospital. So they may have a loved one who also needs to be cared for. They have bills that they have to worry about. There's now a car that may need to be fixed. They may not be able to go home because of their injury complex, so they may need rehab. And so there's all sorts of things that have to be cared for that patient before they can ultimately transition out of the hospital, and we address all of those on rounds. After rounds, there may be meetings, there may be patients coming through the emergency department, there may be discussions with consultants, so subspecialists who we may involve in the care of our patients.
Someone who you just maybe took care of yesterday, who was in a trauma situation.
Yep, exactly.
So when a trauma occurs, everything's out the window, right? You're right there, and you kick into that. With all the machinery, because I know that hospitals have backup generators and all of that, but with machinery that it takes to aid you guys in what you do, is it daily checked? How do you know this is going to work? Because we didn't use it, but it's going to work. What happens in a situation like that? I always think of those things.
So a lot of the equipment is quality assured continuously throughout the day, and there's some equipment checks that need to happen periodically, and somebody initials off that it's working appropriately. If something doesn't work, the patient doesn't care, and we have to work around it. They're here in their time of need, and we need to address that. So if I get an instrument in the operating room that's not working right, get me another one, or I got to figure out a way to work around it.
And that whole thing with which I think is crucial, because it's not just you, Doc, it's your whole team that's working to save the life of someone who set out for a normal day, and unfortunately something happened, and you guys are there. Years and years ago, I'm sure you may have seen this, Gloria Estefan was injured in a bus accident locally, and she went to, at the time, Community Medical Center, the trauma center, and she was there with the major, I think she broke her back, if I remember correctly. Those kind of things, I mean, here they are just going on their bus, and this happens, bad weather, it happens, you do what you have to do. I think to myself, when you hear stories of, because everyone knows her, so it's like, oh my God, it happened right here, and they just brought it up because she won the Kennedy, she was a recipient of the Kennedy Award honors this year, and they talked about, and they showed the scene, and they said in Scranton, and so you think of those things, but the average person who doesn't necessarily understand, we're just grateful we have the location, we have that level 2, as you said, trauma center here in our own backyard. But for the person who doesn't really have to experience it or doesn't understand, it must be very gratifying to you to know you're doing something for a community, that it's your life passion, you're doing it, it's your job, but here you are with the ability to help and to move people on. That has to be so, like you said earlier, it's rewarding to see them get to that level, but also sad in many ways because there's things you can't do. But tell a little bit about that sense of the feeling you get of doing what you love to do every day in a very, very stressful situation.
It's incredibly enjoyable, and my wife will tell you that the days that I enjoy the least coming to work is the days where I don't have patients to take care of, when I'm in meetings or I'm doing administrative things, or I'm writing a journal article or something along those lines. The days that are always the most gratifying are days when I'm operating on somebody because they came in with diverticulitis or appendicitis or cholecystitis, their gallbladder, their appendix, their colon. Something needs to be treated and fixed, or a severely injured trauma patient who we're able to stabilize and have their loved ones be able to reach their bedside to see them and tell them everything's going to be okay. That's the rewarding part.
And the thing that you just said, which I think is important, it's not always that something traumatic happened in a car accident or an accident. It's something that happens to someone, like you said, appendicitis, or something happens where they need immediate attention. So it is traumatic in that way, but it wasn't because of an injury.
Right.
There's many, many other things that you are used for, and your skill is needed because these things happen. Someone coming in an ambulance who had a situation and they need to be taken care of.
Exactly.
And it has to be done quickly.
Right.
It's amazing. Well, what didn't we talk about, because I kind of pulled it all out there, but what didn't we that you may think I missed, or that you may want everyone to understand about what you do and the facility that you do it in?
Sure. I think the most important thing, and any physician can talk to this, but it's the education of the public. And part of being a physician is being that teacher. And so part of the mission from the trauma center is to go out and advocate for prevention and teach people how to address injury before it happens. Things like wearing your helmet when you ride your bike or your motorcycle, wear your seatbelt, appropriately put your kid's car seat in the car. Helping our older population walk around their house so they don't trip and fall, because that's actually the most common injury complex that we see, is somebody who falls and injures themselves, who was otherwise doing great at home, but now we've identified this and they can't go home for X number of reasons. So our big push right now and our big effort is at prevention and education. And a large part of that is with Stop the Bleed, so that we do have more survivors from these traumatic injuries. It doesn't have to be a gunshot wound. One of the analogies I use is when we come up Mulberry Street and we pass the University of Scranton, the kids are on their cell phone, and at the last minute you hit the brakes. That fracture to their lower extremity from the bumper can cause life-threatening bleeding. And so it doesn't have to be the big dramatic thing we see on the news or the political fight that we have about gun control. Is everyday instances can be addressed. Freak accidents can be addressed by educating the public about these different things.
And to pay a little more attention maybe to when you are doing these things, like not walking around texting. And I won't, in all honesty, I don't even talk and walk on my cell phone. I just don't, because I'm afraid to fall over things. So I'll sit in my car longer and finish the conversation and not walk around talking.
Absolutely.
Or if I do, like from my house to my car to my house, I put it on speaker and hold it so I can pay attention. I mean, really, the simple little things that, not that that's always, because I'm doing it, it's right, but I just mean there are things you could do, maybe education, which goes back to that, to try to be a little more thoughtful of what you're doing, right?
Absolutely. And we have classes not only for Stop the Bleed, but for elderly folks about recognizing what their fall hazards are around their house. And we have classes or reminders about putting on your helmet and school-age education. Granted, the Stop the Bleed is important and exciting. It is the CPR for the surgeon or for the trauma team. This is knowledge that everybody probably has in the back of their mind, but bring it to the forefront and really understand why it's important, and understand that you really can help somebody. It's in the forefront of everybody's mind now. But there's lots of education that's out there through the trauma division. If people are interested, we're happy to share it with them.
And what would they do? Just call the office at Geisinger CMC and say they're interested in some education in any of your education, because you do a lot of educational stuff here.
We do.
So, I mean, that could be for anything that could
Absolutely.
reach out. All right, good. Well, thank you very much.
Thank you.
This was enjoyable. And I liked it. Everything I shot at him, I have no questions, and he had an answer. Love it. He's good. This guy's good. Just saying. So we want to thank you for listening and watching. Once again, we had the pleasure of being with Dr. Brian Frank, who is here from New York, and he is home base here in Scranton, Pennsylvania. We're happy to have him at Geisinger CMC. So thank you. We did a nice little series on, believe it or not, trauma surgery. So thank you again. And again, good job, Doc.
Thank you.
Good job. This has been another series of Lackawanna County Medical Society's Public Health Education Series. Thanks for watching.